housekeeping done. So I hope you enjoy the session, and over to you, Louise.
Thank you very much. Thanks for joining. I'm just going to share my screen, and then we can get started. So hopefully you can see that. Obviously, I don't know all your backgrounds or your experience or whatever, so some of it will be really simple, some of it hopefully will be less basic. So forgive me if for those of you that are really experienced, but I just thought I'd try and make it as comprehensive as possible. I am going to talk quite fast because there's a lot of things that I want to try and share with you, but we hopefully will cover quite a lot and have time for questions as well. So just to before I get started, I just really wanted to be very open about any declarations that I have. I don't work with pharmaceutical companies at all. I do no paid work with any pharmaceutical companies. Obviously, I run a very large private clinic, but we do lots of work that isn't paid, and I do a lot of work behind the scenes with a lot of outreach, a lot of other people as well. So my big declaration, as many of you know, is that I take HRT, and without it I wouldn't be working. But the biggest frustration for me is that if I wasn't taking the dose of HRT that I'm on and testosterone, I absolutely still would not be working. So yes, I can get a licensed dose of estrogen and progesterone from my GP, but I can't get an off license or off label dose, and I can't get testosterone because it's off license. And so this is why the individualization is so important, and it's what I learned when I started doing a lot more menopause work 8 years ago by a specialist, and for some reason that's been sort of forgotten. So I just wanted to go back to some basics really. We're from Stratford-upon-Avon, the centre of England, trying to knock Shakespeare off his perch. But also just to highlight, we aren't just a clinic, we fund all sorts of other activities as well. Obviously, not obviously, but I've worked as a medical writer for 25 years now. And so I've done a lot of writing looking at evidence-based medicine, unpicking it for lay press, but also healthcare professionals. And so it's a real privilege to have the podcast, the books, everything that I do to try and help empower people with knowledge. And when they have knowledge, they have choice. And that's what's really changing, I think, in the menopause landscape over the last few years, is that women are having more of a choice. They're having more informed decision making. They're having more detailed consultations really with us as healthcare practitioners, which is really important. I see my role as an advocate to really help people understand and make decisions that are right for them. Obviously, the app allows people to monitor symptoms, but we're constantly updating the amount of information that we give to it. So I wanted to start with a case. So this is a lady, a 52-year-old lady who actually I did a podcast with last week, I think it came out, and she's happy to share the story. She doesn't look like this in the photo, but this was just for, to highlight. So she had taken HRT when she was 45. So, and she said, she felt very good on it. Because she reached 50, she was told, you've been on it too long, you've been on it for 5 years, you need to stop. And then a year or so later, she presented to her GP with heavy bleeding, had appropriate investigations, was diagnosed with a grade 1, stage 1 endometrial cancer. So she had a total abdominal hysterectomy, she had a BSO, and then she actually had radiotherapy afterwards as well. Now, she was told at that time she could never, ever have HRT. And having brought up 3 children, I realised with children, you can never say never for anything. But actually for our patients, I think being told you can never do something is quite a big thing when we have to be looking at the possible risks and also possible benefits of either having treatment or not having treatment. But that's what she was told. She had numerous symptoms, which are very typical. And as you know, not everyone has every symptom, but she had a lot. She was having really awful vasomotor symptoms. Actually, she said sometimes she slept on the bathroom floor because it was cooler for her at night time. She was really struggling at work with her memory. She was writing things down a lot. Her migraines were getting a lot more severe, more frequent. Her sleep was not good. Very anxious. She became very socially withdrawn because she had reduced self-worth. She had muscle and joint pain. She said they were worse in the morning. She could feel her knees creaking. Walking down the stairs was really difficult. Getting out of bed, she said it felt like treading on pebbles every morning. Lots of pins and needles down her arms and legs as well. Her libido was very reduced as well, and she said she felt numb from the waist downwards. She was finding it difficult even to wear underclothes because she has such bad vaginal dryness and soreness. She had urinary symptoms as well and recurrent UTIs. So she, like many, many women we see and speak to all the time, was prescribed a myriad of medications, including painkillers, antidepressants, mirtazapine to try and help her sleep, pregabalin. She'd also tried gabapentin and amitriptyline before, which hadn't helped with her nerve pains and her mood. Lots of antibiotics for UTIs. She tried some CBT sessions as well. She tried acupuncture, especially for her migraines. But she'd given up work as a nurse. She was really struggling. She couldn't care for her 93-year-old mother who lived with her. And so she was very withdrawn. And actually, when I first consulted with her, she was sitting on the stairs. And I found the history taking really difficult because her mood was all over the place, her memory. It was really hard to actually take a history. But she did come, and she was very clear that she wanted to make a choice about not just her immediate symptom control, but about her future health as well. And she said she felt very closed in by the oncologist. It was all about her cancer. She had no one to talk to, and she sought me out for some advice. So I'll come back to her at the end. And then Joanne was a 47-year-old lady who had seen one of our other doctors, and she'd started her period age 14. She used to be really fit, swim for the county, really fit and well. Was always labelled as a rebellious teenager, mood swings, irritability. Her contraceptives had made her feel a lot worse, especially her mood. She was under psychology, she was under CAMS, and then she actually trained as a psychiatric nurse, gave up age 42 due to severe PMDD. She became pregnant when she was 30, but her first trimester was dreadful. Then she felt absolutely amazing. That's really key for people. In her second and third trimester, she had severe postnatal depression. She became pregnant again, age 41, but she again felt dreadful in her first trimester. And very sadly, the pregnancy was terminated because of her mental health being so bad. Age 42, her life spiraled out of control. She went back to gynecologist. She was given some Zoladex, which initially felt good. Then they added back Tibolone, and she felt dreadful. So then they decided to remove as much hormones as they could with a TAH and BSO. She was then given a bit of estrogen, and she said she still had these cyclical PMDD symptoms despite not having her ovaries. She was diagnosed with menopausal depression, but they decided to stop her HRT. And then she became suicidal, diagnosed with personality disorder, possible ADHD, given lots of antidepressants with no effects and lots of side effects, actually. Then tried on quetiapine, lithium, pregabalin. So bad stories, but stories we hear every day in the clinic, actually. And I'm not going to ask you all individually what you would do for them, but it's something that I think we should be confident in enabling. We've got guidelines. Obviously, the NICE guidelines are quite old now, and guidelines are there to help and advise, but individualized care is the most important thing. And I think the most important guidelines for any consultation, including when it's about hormones, are shared decision-making guidelines from NICE. Some of you, I'm sure, will be very confident thinking about the menopause. I actually can't stand the word menopause because actually a year since our last menstrual period means nothing to those women who aren't having periods. And it means nothing to a lot of us who are struggling when it hasn't been a year since our last period. Defining as end of reproductive age, I think as well, is very disparaging for some ethnic minorities, some communities where it's very stigmatizing to not be fertile. But actually, as you know, women with POI can still become fertile depending on the cause of their early menopause. So it's not accurate. But actually, the time before menopause is more crucial. For many women is when we get most symptoms because it's a time of chaos and hormonal change in our bodies. If we're only talking about menopause, we're forgetting perimenopause. It can last for a decade or so, but we're also ignoring PMS, PMDD, and postnatal depression. So we have to be thinking about the hormones. And I've just sort of had a play on words thinking about the WHI, which is the biggest car crash for women's health, as you know. But let's think about it more of a women's hormone insufficiency. There are times when it's a deficiency, times when it's an insufficiency, and actually also in the perimenopause time when hormone levels can be high as well because they rise as well as fall. It's a massive problem, and it's getting bigger, not just because it's spoken about more in the media, but women are living longer as well. These are some very simplistic posters, which I'm not talking through, but I want people to understand that estradiol, progesterone, testosterone work on every cell in our body. They regulate our immune system. They're very anti-inflammatory. They even help mitochondrial function. They are really key hormones, really important, and they're not just produced in our ovaries as well. They are neurosteroids, and they are made and manufactured in our brains too. What's really important, and I've learned more and more running the menopause clinic, in that we have to be thinking about reproductive depression, which is a term that John Studd used many years ago. And so if women have PMDD, they're more likely to have postnatal depression and more likely to have mental health problems during their perimenopause. So it's really important to be mindful of that. We know diagnosing is really hard, often on clinical history. I don't do FSH levels, even in younger women, because I've seen so many women with normal or suppressed FSH levels, and they've been absolutely perimenopausal or menopausal. A lot of people we see are on drugs such as quetiapine, which will increase prolactin, which then switches off FSH, which then will reduce estradiol, progesterone, and testosterone. So it's not actually helpful to do FSH, I don't think, at all. So give women information. Obviously, we've got the app where they can download the health report, symptom questionnaire. We are producing a new symptom questionnaire, and if anyone's interested in piloting it, then please email Katie or me directly. Is absolutely fine, because we want some feedback before we put it out to more people. So I'm not going through the symptoms, you all know, but this is quite an interesting word cloud that I did based on 3,000 or so women I questioned about their symptoms. And the bigger words are the symptoms that are more common, mostly brain symptoms. No surprising, because our brain is so important and doesn't work as well when hormones are fluctuating in our brain. Testosterone deficiency is really important. Thinking about testosterone, I know everyone talks about libido because that's where the studies have been done with testosterone replacement, but a lot of people, even vasomotor symptoms, can be due to testosterone deficiency, especially mood symptoms as well. We see a lot of people that have been under psychiatric hospitals, and they improve a bit with HRT, but improve more with testosterone. And we've just had a paper published, well, it's published soon, it's been accepted, about this too. As many of you know, there are risks to health without our hormones, and we can't keep ignoring this, because the longer we are without our hormones, the greater the risk of inflammatory diseases. So let's get on to treatment. To me, the most important thing about treatment is empowering our patients with knowledge and information so they can make decisions. HRT is not a one size fits all. And I don't even like the term hormone replacement therapy, because we're not replacing. Often in the perimenopause, we're topping up. Therapy sounds like we need a couch, and it's more of a talking treatment. Some people call it MHT, menopause hormonal treatment, but it's not just menopause. We can give hormones to women who are perimenopausal, and we can give hormones to women with PMS and PMDD, of course. And so individualizing is really important. Unless there's a really big reason not to, I'll always give estrogen, progesterone, testosterone individually. So you can change the dose, you can change the order you give it. But also, I always, unless there's a real problem or reason, I will only prescribe the natural body identical hormones. I've been doing a lot of reading about synthetic hormones. Some of you might know I'm doing a theatre tour, which any of you are welcome to come to. And I've been reading a lot about the studies with the synthetic hormones, especially the contraceptives, actually. And they work very, very differently to our natural hormones. So of course they're going to have different side effects, they're going to have different risks as well. But we have to remember that these that I've shown on the screen just contain estradiol, which is the very anti-inflammatory type of estrogen, very different to estrone, which oral estrogen gets metabolized into, very different to conjugated equine estrogens. that had a myriad of estrogens in it. You can imagine pregnant horses' urine, but they also contain progestogens and androgens in, and goodness only knows what else with these poor horses that were trapped, producing lots of urine for Wyeth to make conjugated equine estrogens. Very different. So when you look at any of the studies, any of the data, you've got to be really clear. Is this about synthetic hormones, or is it about the body identical natural hormones? Because they are biochemically and physiologically very different in our bodies. So there are benefits. Of course, there are benefits of taking hormones, because if we get the dose and type right, we'll improve the symptoms. And we know even from the guidelines that are more conservative, because they look at HRT altogether, including synthetic hormones, but the benefits outweigh the risk for most women. But we do know the data, despite what people sometimes talk about on social media, that our hormones, if they're given naturally, will reduce the risk of inflammatory diseases, which makes sense, of course, because they're reducing inflammation systemically. The dementia risk has always been a bit of a confusion, because often some of the systematic reviews are looking at synthetic hormones as well as the natural hormones. And as you know, the synthetic hormones do have a small risk of clot and stroke, as well as probably dementia. Whereas we've known for decades how important the hormones are in our brains at reducing inflammation, helping even myelin, building up myelin, helping neuronal activity, helping neuroplasticity, helping blood flow to the brain. They work as neurotransmitters. So of course they're going to help with improving cognition and reducing dementia. Most women don't take HRT. Areas of deprivation, very few women take HRT. Some of you might have seen this on our website. Sarah Glynn, who's an absolute genius, for those of you who don't know her, she's got a master's in immunology, she's a doctor, and she's a menopause specialist, doesn't do her clinical work with us, but academically works with us. She's produced these little pictograms looking at the benefits and risks of body identical HRT, so different to other charts you would have seen. And there's lots about the benefits. Really important to look at that, and good to show our patients. There's less for risks, but actually if you look at the risks, she's compared synthetic with natural hormones. And so actually we know there aren't risks with the natural hormones, and there are benefits with estrogen only HRT. WHI showed lower breast cancer risk, of course, as I'm sure you realise, but these are useful to share with patients, and they're on our website, and Kat can put the link in the chat. So the dosing of estrogen is really important. I just want to take you back to basic pharmacokinetics, actually. Our skin is a barrier. It's not meant to have drugs going through it. When I rub on moisturizer or sun cream, I don't really want it to go into my bloodstream. Estradiol is the right sort of size that it will go through our skin. But when we use patches, obviously it sticks onto the glue is impregnated with the patch with the estradiol. So there's lots of things that affect when we give a drug, but obviously the absorption. So it depends on the skin type, the temperature, the blood supply, how much collagen is there, how much subcutaneous fat is. We know from some studies there's a 22 variation between putting a patch on your bottom compared to the back in the same individual. So absorption, and then it's got to be distributed, it's got to be metabolized, and then excreted. And so, of course, it really varies between individuals. These are very old quotes from old studies to say that the same dose of the same hormone ingested by different patients will not necessarily provoke the same hormone levels, of course. And there's going to be variation between estrogen clearance as well. And both oral and non-oral formulations will produce different responses and have different levels in women. And so titrating is really, really important. We know that with other drugs, but there's something about estrogen that gets people really fired up. This is really important because some of you might know there's lots of people say, and we get lots of patients who are told they can't have higher than the licensed dose of estrogen. Now, actually, when you look at how the drugs are licensed, all they want to do is, does it stick on? Is it okay? Estradiol, for example, doesn't have a maximum licensed dose in Belgium and Germany. It's only in UK and some other European countries. But when you look at the number of people in the studies where they used to license essence their maximum dose. I've put a big red ring round because you'll see all the numbers are less than 40. And if you look in the column 2 along, duration of application, some is actually good, it's 7 days, look at that. But a lot of them are only 3 or 4 days. So they're basically looking at less than 40 women for 3 or 4 days, or maybe 7 days if you're lucky. And that's where the studies are used to look at 100 micrograms. But they did show, when you look at it, actually, for about a fifth of women, the absorption was less. That is no surprise. And I know when I started my HRT, I didn't absorb very well. I still felt awful. I didn't feel great. I went back to my consultant and he said, oh, well, let's just increase your dose from 1 to 200 micrograms. And this was many years ago. And I thought, oh, that seems a bit high. And he said, no, but Louise, your estradiol level is low. Why don't you increase, and then you can see it. And within days, my night sweats improved. I started to feel quite a lot better. But my patches don't stick on particularly well. That was when I was perimenopausal. I'm now menopausal and use 300 micrograms. And if I use less, I get joint pain, muscle stiffness, I get worsening migraines and feel absolutely dreadful. And for those of you that are worried about me, my level has never been above 440, despite being on 300 micrograms. So some people do need higher levels, and often it's poor absorbers. And we've just had a paper accepted in Menopause Journal, which will be published soon. And we've paid for it to be open access, so you can all read it and absorb it and divulge it and hopefully enjoy it, because it does show in our clinical practice that around 1 in 5 women are not absorbing well. They're needing a higher dose to achieve the same symptomatic benefit. We know that some women from studies need more, especially if they've got severe psychological symptoms or they've had a surgical menopause and are younger. I was reading a paper recently from 1999 where they gave 25 milligrams of estradiol to women in psychiatric hospitals with a really good response. Now, this was pre-WHI. 25 milligrams is a good going dose, like far higher than I've ever prescribed, but it's well reported that it helped, and it might be that people need higher doses to go through the blood-brain barrier. For some women, so I get really awful migraines, and so when I was perimenopausal, my migraines were triggering a lot more, and actually using a higher dose, I'm sure, stopped my hormonal variation, and which was a lot better for my brain and reduced migraines, and we see that quite a lot. We have to remember the dose that we're using here, even when it's 300, is less than we would give in the contraception. So are there any harms? People worry about the harms of using higher doses. Well, no, because if you're absorbing not very well, you're not going to get as much into your bloodstream. So I'm probably absorbing, and I know I'm absorbing less than many women who use 50 or 100 micrograms. So it's not the dose I'm being prescribed, it's the amount that's getting through my skin. And actually, if I don't use enough, I've told you I get symptoms, but also we know that when women have low estradiol levels, it primes the immune system in a wrong way. It becomes pro-inflammatory. And we know when there's adequate estradiol in the blood, our immune cells will actually genetically reprogram. They'll increase their number. They'll increase and change the cytokines that are produced from them, and they'll be more effective at the way that they work. We've known that for many years. There's some great papers from the 80s, if any of you want me to share you with them, showing how our immune system is primed so well with estradiol, but if it's too low, it doesn't work as well. Some concern about what about high levels? Is there a VTE risk? We've been monitoring all our clots. We made everybody record for a year whether women had a clot or not, and actually the numbers are so small we can't even do any statistical significant stats on them, because we haven't had people with clots. And why would we? Because we're not using higher amounts in the body. There was one paper many years ago looking at implants and clots, but it's quite a messy study, so you can't really interpret. But estradiol doesn't cause clots. The clots are with the synthetic hormones, and again that's the same with stroke as well. And we know that there isn't an increased incidence of breast cancer in women using estradiol. So then looking at progesterone, do we have to increase the dose of progesterone? If we increase the dose of estrogen, when do we know what to do? Well, we know there's been a lot in the press with this new guidelines by the BMS. Some of you might know. We know there's been more referrals for bleeding because there's been more people taking HRT. We know that estradiol can cause hyperplasia because that's what it does physiologically. But actually, we haven't got any studies that show that estradiol causes endometrial cancer. We know that there are some observational studies that conjugated equine estrogens can cause endometrial cancer, but that is not the same as the natural estradiol. And we have to be really careful when we're talking to our patients about risk. Some people will say, well, one of the risk factors for endometrial cancer is obesity. Women who are overweight have more estrogen. Yes and no, they have more estrone, which is produced from adipocytes, but our adipocytes produce more pro-inflammatory cytokines as well. And we know obesity is overtaken smoker as a risk factor for all types of cancer. We also know that women with PCOS often have a very irregular periods, might have more time with unopposed estrogen, but they are also very pro-inflammatory. They have metabolic syndrome, often increased risk of cardiovascular disease and diabetes. So therefore, the etiology and the pathophysiology for their cancer isn't as simple as estradiol. So we don't have, and if anyone's found evidence, please give it to me because I can't find any showing that pure estradiol causes endometrial cancer. Yes, it can cause bleeding. Yes, it can cause hyperplasia, but hyperplasia is not the same as metaplasia or carcinoma. So what dose of progesterone should we give? Well, the reassuring thing with just to sort of also reassure you, all these referrals with increase of bleeding that's causing a bit of mayhem for the gynecologist hasn't resulted in an increase of endometrial cancers, which is crucially important. What I wanted to share with you here, and we can share the slides because this is quite busy, but I'm going to focus in a second. This was an abstract that we had as a poster for a gynae oncology conference recently, and we were looking at our bleeding and our scan results with women who had an increased endometrial thickness. And this is really important, these two figures. The first one showed that there was no correlation between estrogen dose, and when we say pump equivalent, so if someone was on 50 microgram patch, we will say 2 pumps, or if they were on 100 micrograms, 4 pumps, or 200 micrograms, 8 pumps, just to make it easy, really. So they weren't all on gel, they were often on patches. So looking at the endometrial thickness, and you'll see some people, like there's these aberrant dots, but even there's a big range. So there are some people who are on 3 pumps who have thicker endometrium than others who are on 8 pumps, which you would expect, common sense, because they absorb differently. And then we also looked, were they on cyclical or continuous HRT? And no surprise, actually, that the cyclical women on cyclical HRT had a more likely to have a greater endometrial thickness. And it's important if they're having scans that ideally they have a scan after they've had bleeding. But this is really reassuring. So this data, with the data that we're having published about our endometrial, the estradiol doses, I think it's really important to reassure us that when we are giving estradiol, we're giving it for the right reasons. So to knee-jerk increase progesterone dose because someone's on higher estrogen doesn't actually make sense, because someone like me, who absorbs less through a higher dose, and if I wasn't having bleeding, why would you knee-jerk increase progesterone? Some people, we increase progesterone because they're having bleeding regardless of their dose, especially if their scan is normal, and that can help. Some people, if they're on a low dose of estrogen and they're having bleeding, increasing estrogen actually can stabilize the endometrium and stop bleeding as well. So it's very, very individualized. I don't think we should be blanket giving the same dose to the same people because people are different. So we should just tailor to the individual. We should be looking at the individual clinical circumstances. We also need to take really good histories, because I've seen so many people that have been sent for 2-week referrals and they've had sex, but they've got really bad vaginal dryness and soreness. Or, you examine them and it's very obvious that there's something else going on. Or they say, yeah, I went on holiday and I forgot to take my progesterone for a week and then I had bleeding, but now I'm back on it. It's absolutely fine. So we have to be careful. Look at the level. Estradiol levels are useful. They are a guide. They're not a panacea, especially in the perimenopause, because hormones fluctuate, but they can be useful. We need to look at bleeding patterns. We obviously need to look at risk factors for endometrial cancer. Some women really can't tolerate progesterone very well. And so if you're increasing to everyone, some people I know work shifts and they cannot tolerate 200 milligrams because they feel so tired. Sometimes actually changing it from oral to vaginal can make a big difference. And so we need to think about that too. And we need to talk to the patients as well. And we need to just discuss them. This is an uncertain area of medicine. We haven't got any evidence. Unfortunately, the gynecologists haven't collected the data that they've had for years. And there might be risks with higher doses of progesterone. We don't know. And so often it's working with the patients about uncertainty too. I just wanted to share this with you. This is, I know some of you might think I'm a bit mad, but I had my own levels done 8 times in a day, and they were venous samples, 4 from one arm, 4 from the other, different times in the day. I changed my patches a couple of days before. I haven't changed my dose for, I don't know, 18 months or so. But I wanted to show you really that my estradiol level really did vary throughout the day. And of course, I'm probably producing, hopefully, some estradiol for my ovaries still. Don't know whether they're still working. My brain, my heart produces estradiol, my muscles do as well. And I metabolize it differently depending on whether I'm stressed or exercising or whatever. So they can really vary estradiol levels. But then just also I wanted to talk about testosterone. So testosterone, again, who should be using it? We don't know, do we? But we do know that levels reduce with age. It's more of an age related than a menopause related. Unless people have their ovaries removed, half their testosterone will be lost overnight, of course. Then we know we've got criteria for HSDD. I feel the criteria is very restrictive, talks about people being severely psychologically distressed with their reduced libido for at least 6 months, which is a long time for women to suffer. I didn't go into medicine to watch people suffer in that way. I don't quite know why there's so much restrictions for testosterone when it's another hormone that's biologically active, the most biologically active hormone we have. We produce more testosterone and estrogen when we're younger. The 2 main preparations that I would recommend, and we usually recommend in the clinic, is either Testogel or the Androfen, which is only available privately at the moment. Personal choice. Testogel, if it's private, is slightly cheaper. Some people find it absorbs better. Other people find Androfen easier to apply and absorbs better. So again, it's about choice. Usually around 1/10 of the male dose. Although the sachets, we often say more like 7 to 8 days. And there are some women, for example, with PCOS who might need slightly higher doses. Other people are fine on lower, very individualized. If we're using Androfen, it's 1/2 ml a day that we start with. But obviously wash their hands after they apply, and wait. Actually, that's really important because it can take 3 to 6 months. Same with HRT, because you've got the immediate metabolic effects going on in the body, affecting various pathways in the cells, but you mustn't forget the genomic effects. So it can affect the way our genes work, and that will take a longer time to have an effect. And that's why for many women it takes quite a while to have an effect and a benefit with hormones. So we always do, or we always offer, don't do everything for everybody because it's about informed choice. So we'll offer about doing baseline blood tests, quite useful to see how low it is. We do free androgen index, so do their SHBG as well, review and follow them up after 3 to 6 months. And then the level really is a guide. If they're low and they're feeling fine, we don't always increase it. If they're still having symptoms, we can increase it. But we have to be really careful about looking at hormones. And this, again, was my blood test done over a day. And actually, what you can see by this is that my levels really changed. I was quite surprised. I used Androfen in the morning every day. And so at 5 o'clock in the afternoon, if someone had seen me as a patient and done my blood test, you would have said, oh, your level's 3.5. That's a bit high. You need to reduce. if you'd seen me at 10 o'clock at night, you would have gone, oh, Louise, that's a bit low, you can increase. But actually, I haven't got a beard, I haven't got a moustache, I have no side effects from it. So actually just shows that actually you can just see. So if you have a high level in a patient, look at the patient like any other blood test you would do. And often we say, if you're feeling well, let's repeat it in a few weeks' time and then assess. And again, if they're low but they're feeling well, don't necessarily need to increase it as well. But I just think this is really important to share with you. Just wanted to mention very briefly GSM. Obviously, it's not just estrogen, it's testosterone as well. We have in our vulva, vagina, urinary tract, pelvic floor, everywhere. We know the symptoms, but urinary symptoms are really, really, really common. Vasomotor symptoms might improve with time. GSM symptoms don't. We need to remember them in older women. And this is a picture that I grabbed from an Italian colleague. That's why it's all in Italian. But you'll see that the pink is estrogen and the blue is androgens. So we have the same number of testosterone as estrogen receptors all around our vulva, vagina, clitoris, and pelvic floor as well. So we can't ignore testosterone. And so first line, I usually now give Intrarosa. I know it's not on everyone's formulary, but it should be. It's a daily pessary of Progesterone, which converts to estradiol and testosterone. I can't remember the last time I prescribed Vagifem. Often prescribe like some Blissol gel or estradiol cream if they've got external symptoms as well. So just quickly before I finish, Leslie said to me, I felt like I was sinking through quicksand and you lifted me out. Thank you. I've been involved in all the decision making and I have felt listened to. It is my body and my choice. Really important words. And really important, she's a nurse, quite a senior nurse. She's back at work. She's caring for her mother. The treatment you've given me has a truly miraculous effect so far, and I hope you will allow me to continue. I think that's the saddest bit of this quote, because it's not about me allowing, it's about her wanting to. Then going back to Joanne, she saw one of our doctors who gave her a higher dose of estrogen, gave her testosterone as well, and gave her vaginal progesterone, 400 milligrams, and she started once a day, went up to twice a day. And then she cancelled her follow-up because her GP was prescribing, and she wrote to us and said, please thank Dr. S for her amazing assessment and support. The improvement has been life-changing. Now, it's taken her decades to get the right help. There are a lot of teenagers struggling like she is. So we know the diagnosis is clinical. We know symptoms can be terrible. Hopefully those of you on here know that HRT is safe. We need to remember that antidepressants work better in the presence of estrogen. Think about testosterone as well. I don't know how many of you have done our course, lots of case presentations where people can go on. And today we've launched the masterclass, which is for anyone, actually. But it's really made for people, women, but men as well, just to learn more and more. I've done some great interviews with lots of other experts as well. It took me a long time to do. So I hope you can enjoy that as well, and Kat can put the links. So I haven't been looking at the chat. I hope there's been some questions, and sorry that I've spoken very quickly, but I do want to give yourselves time as well. So I'll hand over to Katie to field the questions, if that's okay.
Hi, Louise. I think we've got Kat joining too. She's been taking down all of your questions in the background, and I've been emailing a few of you in the background asking for the survey as well. So we're doing a double act.
Yeah,
thank you.
You've got two for the price of one tonight. Hi, everyone. Right, I've been keeping a record of, got some really good questions coming in. We've also had some on email ahead of the event as well. So I'll just kick off. One of the questions we've had is, when do you check hormone levels to monitor / adjust dose, and what levels are you aiming for?
Yeah, it's a really good question, and we've actually in the clinic been very fortunate because we work very closely with the lab that we work with, and we've reduced the prices because I'm very conscious of having a private clinic, that I don't want to fleece women, and actually clinically I don't want to do a test that's not going to change my management. So we usually do blood tests actually when we first see people for two reasons. Actually, I want to make sure there's no other reason, and we have picked up lymphomas, we've picked up liver disease, we pick up a lot of low iron, low vitamin D, actually, sometimes borderline or low thyroid as well. So we just do those blood tests if women want it and they haven't had it recently. Our blood panel does include estradiol, testosterone, SHBG, and it is useful. But I always say to patients, it is a guide. I've never once met someone with normal testosterone levels, but some people it's very, very low. And increasingly I'm seeing it, younger women have very low testosterone levels. Estradiol, like we know physiologically, it's usually between 250 and 1,000, but I've been trying to find studies and I can't find good studies where they've done it. So I don't know. But that's usually what we go for. But we have to remember that in the perimenopause, levels can be really high. So sometimes you see people and their levels like 2,000, 3,000, and you've not even started hormones. So you just take it with a bit of caution. And then we usually see people after 3 months do their levels then. And if their levels are normal, so like between 250 and 1,000, then it doesn't, but they're getting symptoms. Again, it might mean that they need a higher dose. It might mean you need to change from patch to gel or gel to patch, or adding in testosterone. So testosterone, because it helps with so many symptoms, there's no point keep increasing estrogen if they're going to benefit from testosterone. But if someone like me, I know I keep talking about me because it's all about me tonight, clearly. If I'm on 100 micrograms and my level, which it was 110, and I was still getting symptoms, it makes sense to increase and then monitor as well and see. But it's just like any blood test in medicine, it's a useful guide. But I do think they're worth doing. I know lots of people say that they're not worth doing, but I think they often can be. And the testosterone is just very reassuring, I think, for people to know that they're within a female range.
Brilliant, thank you. Okay, on to the next one. What do you do with a patient who has breast tenderness that gets worse with increased estradiol?
Yeah, so breast tenderness is interesting because when you look at it, often it's more with the progesterone than estrogen. And so it's often the balance of all three hormones, actually, estrogen, progesterone, testosterone. So take a really clear history, make sure it is the estrogen and not the progesterone. Testosterone can be quite it's very anti-inflammatory, but it can be quite reducing on the breast, so lower breast pain and actually sometimes reduce breast size as well. So sometimes when people have got testosterone on board, they can tolerate estrogen better. If they're perimenopausal, it's the fluctuations, I think, that can trigger some of the breast tenderness as well. So it's just finding the right dose as well and reassuring women that breast pain doesn't mean breast cancer, because obviously everyone's scared about breast cancer. So it's just working with the patients and finding, but some women are just more sensitive than others. And we have got a leaflet, haven't we, Kat, that we've written about breast tenderness as well. That's quite helpful, yeah. just some simple measures for patients as well.
Yeah, I'll try and share the links, and if we don't, we're going to have in the coming days, there's going to be an email with a link to watch back the webinar, and we'll also include some helpful links as well. So back to questions, we've got some really good ones coming in. What's your suggestion for women with PMDD who are unable to tolerate Progesterone orally or vaginally?
Yeah, that's a really good question, because a lot of women with PMDD and PMS and perimenopause, but lots of them are very progesterone intolerant. But when you really take a history, a lot more of them are progesterone intolerant. So they might have had an awful time with a mini pill. I've known people that have taken out their own marinas or tried to rip out their implants from their arms. But that's not the same as progesterone. But also, some of you might know Katrina Dalton's work, who was amazing in the 50s and 60s and 70s, actually, who did a lot about progesterone, proper progesterone. And she gave higher doses, like 400 milligrams, 3, 4, 5 times a day. Progesterone is very short acting, especially when it's given vaginally. And so sometimes women have had an awful time with low dose, but actually when they have it as a higher dose and cyclogest rather than giving Progesterone, because it's actually made as a pessary, so it gets absorbed just more reliably sometimes with those people that are very sensitive. And I always say to patients, it's really, really short acting. So if you feel worse, you're not going to feel bad for long, but you might find that it really makes a difference. So it is worth bearing with. But there are a lot of people also with PMDD that it's more estrogen deficient than progesterone, or it might be testosterone. I've seen a lot of women recently who have had very low testosterone. They're in their 20s and 30s. They improve a bit with some hormones, but it's the testosterone that's made a biggest difference for them, especially when they have urinary symptoms or lichen sclerosis. So it's just looking at everything together is important.
Right, thank you. Next one, the message that dosing is individualized is very clear, but what would be reasonable starting dosages when you're starting out?
So again, great question, but it depends on the symptoms and it depends on the patient, and especially depends on the patient age. Actually, I was quite surprised 8 years ago when I started HRT. My consultant just gave me 100 micrograms, and I was like, oh, and that's quite brave because I'm a migraine sufferer, and so if I was prescribing for myself, don't worry, I don't prescribe for myself, but if I was prescribing for someone like me who has migraines, I would start actually quite low, and I would get them to, and I would probably maybe prescribe 100 and say, cut it in a half and a quarter, do a quarter for the first month, and then gradually increase, because any quick changes can trigger migraines. I saw someone today who's 67, never had hormones before, been diagnosed with fibromyalgia. I don't think it's fibromyalgia. So I've given her Oestrogen. She's going to start 1 pump a day for 6 weeks, then go up to 2 pumps a day, because she's more likely to get side effects if she has a higher dose. Younger women often do need a higher dose, and you could start with 75 micrograms or 3 pumps. It really, really varies. But often I'll say to patients, try this dose, and then you could increase, so they're not having to come back all the time. It really is, it does depend.
Great, thank you. Another one here, if you start cyclical HRT in perimenopause, when can you change to continuous HRT?
That causes a lot of confusion. Actually, we have to remember that the body likes homeostasis. It's always better to have things the same, and especially the womb, because you're more likely to have bleeding if you're going to have cyclical progesterone. So usually after 6 to 12 months, depends on the women. If the women quite quickly are saying that their periods are lighter, that they're quite regular on the cyclical progesterone, then I'll say to them, would you want to try and not have your periods, because that is probably the main advantage of menopause, and then change them so they have one every night. But say to them, if then you start to get really irregular bleeding that's hacking you off, go back to cyclical for another 6 to 12 months and then try it again. So, because I've spoken to women who have had POI in their 30s, they've been told by gynecologists, wait till you're 51 before you can change to cyclical, and they don't want periods. But conversely, there are some young women who want periods because it makes them feel younger. So of course they can carry on. It doesn't matter, but there's nothing magical that we have to wait 1 or 2 years before going to continuous.
Right. This is my favourite question of the night, and it's not a plant, I promise. Is the new menopause masterclass aimed at lay people or practitioners, and how does it differ to the Confidence in Menopause course?
So it's completely different. It's probably one of the best things I've done, partly because I was with some really good camera crew that had the most amazing lighting that made me look really, and that had a great makeup team and everything else. But I developed it with Kate Muir, who I work with, and she did all the Davina documentaries, and it took a long time to write and produce. It's really for lay people, but I'm hoping that healthcare professionals will enjoy it as well. So I'm talking to Isaac Monyander about testosterone. I'm talking to Jeffrey Hackett about testosterone in men as well. So there is a bit of a male thing. Talking to Alison Metcalf about HRT and breast cancer. Talking to a divorce lawyer about divorces. We've got real life stories of real people as well. I'm talking about nutrition. I'm talking about yoga. I do a headstand on it as well. So it's very holistic. It's something for everyone. And then I just go through basics about hormones as well. But I've kept it really general. It's not, it's really so people can dip in and out. They can watch it. They can invite people over, and I've done it in quite a timeless way and not UK centric. So anybody in any country can watch. But give us your feedback if you like it or don't like it. But I hope you'll enjoy it, because it's been a huge amount of work, but it's a real privilege to have a long time that's uninterrupted to really get into basics with people.
Great. I've just also shared the links to the masterclass under the Confidence in the Menopause in the chat as well, so you can find out a little bit more if you want to. So back to questions. What are your thoughts about switching women after 5 years sequential HRT use, regardless of age, to a continuous regime purely for endometrial protection?
Yeah, I wouldn't wait 5 years. I would just do it a lot quicker. It's better. A lot of women find it a lot better for them because they're not having periods, and it is better for the endometrium because when you're continuous, you're less likely to have bleeding, of course. But the other thing is, every time we change a dose of HRT, warn women that you might have bleeding for the first 3 to 6 months. And if you do get it, then don't be alarmed. But I also always say to women, if you're concerned, if your bleeding is very heavy and you're worried in any way and it's different to what you expect, then just talk to us, make sure that you have a consultation, because you don't want women suffering with bleeding and thinking, oh no, it's supposed to happen for 3 months, I'm not going to tell anyone. And we pick up a lot of fibroids, a lot of polyps, a lot of adenomyosis actually as well, and that can be the cause. So everyone gets really fired about cancer. Like, we have hardly any endometrial cancer in our clinic. We've got thousands of women. It's less than background incidence, but we have to be looking, and that's why taking a really good history is important as well.
Brilliant. So this is a question about progesterone. So if a perimenopausal woman is taking continuous progesterone, 100 micrograms, yet her cycles continue to be less than 21 days, do you find switching to cyclical progesterone helps to lengthen out the cycle?
Yeah, it can be. We've had some women who just their bleeding is just not quite right, and they might be in their late 40s, 50s, and then we change to cyclical, and they just feel so much better because you get more of a regular cycle, and that's absolutely fine. It really is so individualized, and that's why spending a bit of time talking to the women and allowing them to choose and try, I think is important. And some people prefer to have a regular light period even well into their 50s than having something that might be more frequent or more chaotic.
Thank you. Or like this question. Do you think we're getting any nearer to a female formulary like Androfem of testosterone being available in the UK?
Yes, I think yes, and I'm saying but because I went to a meeting with the MHRA pre-COVID, which feels like about 100 years ago, where we were trying to, I just went as an advisor with Androfem, and they were looking at it then. I know they're looking at it now. They say it's not a priority. Obviously, they're pushing through lots of other drugs at the minute, but they are closer to it. The last I heard, they've come back with some questions. It should be, really. It is licensed in Australia for women, so there's no real reason. It used to be licensed as the patch, as many of you know, but I don't know. It just seems to be, I was told it would be by spring, and then it was by summer. Now it might be by autumn, so I don't know. I'm not holding my breath.
Okay, sounds like a watch this space. Okay, this is a question, another progesterone one. We're getting lots of progesterone questions tonight. If a patient has a Mirena coil but wants micronized progesterone as well, how much micronized progesterone can we give?
Yeah, that's a great question. I've thought a lot about progesterone recently, having read a lot of Katrina Dalton's work, and one of our doctors, Hannah Ward, is just a genius with progesterone. I've done a podcast with her. It might be worth listening to if you're interested. But I've always been told that, you give estrogen, you give progesterone if they've got a womb, and then you only give testosterone if they are really low in their libido. But actually, progesterone is a really good hormone, as we know. Progesterone converts to testosterone, which then converts to estradiol, and it's a neurotransmitter. It's produced in the brain. We've got receptors all over our body. So why are we just giving it to women if they've got a womb? So increasingly, we do give it to women who've got Mirena coil or who've had a hysterectomy. I see quite a few women who were on progesterone told to stop it after a hysterectomy and then feel awful. So if women want to try it, then I don't see a reason why not. And I have done an Instagram live. Kat might be able to find the link recently about progesterone that any of you could watch. And women are often watching it saying, like, I'd like to, and I've got quite a few women who've had a surgical menopause who feel dreadful. You optimize their estrogen, optimize their testosterone, they feel awful. Then they have progesterone, often vaginal progesterone, and feel amazing. So the doses is the same whether they were having Mirena or not, but you're not using it for endometrial protection, if that makes sense.
Great, thank you. This one here. What is the situation with lichen licensed sclerosis? A connection is seen with declining estrogen. Could HRT be a therapy option with a steroid? And would intrarosa or vaginal estrogen be recommended in addition?
Yeah, absolutely. But I think it's more testosterone actually than estrogen. I feel really bad for the women I saw and consulted with in general practice who I gave loads of steroids, cream to, and some Vagifem. It can be game changing. I've got a 27-year-old who's got such severe lichen sclerosis that she was told by the dermatologist and the gynecologist that they'd never seen it so bad in someone so young. She also had recurrent UTIs, and it's been completely transformed. Her vulva looks normal now, and that's on intrarosa and systemic hormones. So I'm trying to persuade my husband, who's a urologist, to prescribe it for some of the men, but you can only get pessary, but you can't really put that down someone's urethra. But it's really, I wouldn't prescribe steroids first line. We know the problems with topical steroids. So I wouldn't bother with topical estrogen. I would just go for progesterone. And if it's not on your formulary, I think you should really demand or prescribe it. It's not actually much more expensive either.
Okay, great. We've probably got time for just 2 more questions. So this is one that's come in recently. Broadly speaking, is there a better time of day for bloods?
Yeah, it's a good question. No, I think sometimes, and some of our doctors do say, you can avoid the morning dose if you're having it in the morning, if you want to try and have more of a trough level. Just be really careful they don't use it on their arms, especially estrogel. Don't use it on the arms the morning of them having the test, because you will get a falsely high reading. So mostly they use testosterone on their legs, so not to worry. But but just have a low threshold for either repeating it or interpreting with caution, really, if the levels are raised.
Okay. And we're going to wrap up because our hour is almost up, unfortunately. I think we could probably keep going all night. So final question, is there any hope of seeing Progesterone as a cream anytime soon?
No, because there's no interest by pharma because it's so cheap, but it can be compounded actually. And I mean, compounding is a different conversation. It just means they make something up where it can't be given license. We don't compound other things. We don't give pellets or implants. I don't use any of the sort of lozenges or like the biased and things that we see all sorts of people coming from. But progesterone cream can be made up. Most people get on really well with the pessaries. They come with a reusable applicator, and I always say to people, it's a bit crude, but you have to insert it quite high up, because if you don't, often the wax, because it's quite waxy, will melt, and then they get this waxy residue in their pants and hate it. Often I'll say to people, use it in the morning, because when they use it at night, I think it's just because they're lying in bed all night, then they get up and then they get this horrible waxy stuff dripping down their legs, which isn't very nice. So using it in the morning, shoving it up as high as possible, actually most people really do tolerate it well, and they can use it without the applicator, of course, as well.
Brilliant. Okay, well, everyone, I think our hour is almost up. So, Louise, was there any final thoughts from you before we close?
No, I haven't had my glasses on, so I don't know how many questions that we haven't answered, but I hope give us some feedback in the chat. Katie leads all our clinicians, so I'm sure she can get some of our clinicians to do like a Q&A, because I know I've talked a lot and presented, but sometimes all you want is some quick fire Q&As, and I've done that with Mims Learning quite a few times and it's gone down really well. So if there's an appetite for like just a Q&A, I'm sure Katie and Kat could organise with our doctors. We're really keen to engage with people as much as possible and share our knowledge and information, our guidelines, our pathways, everything that we do, because our mission as an organisation is to help as many women as possible. We're quite unusual. We don't want them all as patients. I hope you agree with that, Katie. But so any ways that we can, enable people to be more knowledgeable, more confident. It's a real area of it's become very uncertain, but it's not uncertain in my mind. It's very basic, easy medicine that's become complicated by politics, unfortunately. So we're very happy to help. Any of you can email through. I mean, my email is very obvious. It's just louise.newson@newsonhealth.co.uk. And ideas where we can interact. If any of you want to present with us, we're very happy to do that as well. We're always looking for like-minded people just to learn from. And if you've got things that you want to share and experiences or cases that you want, or also we're doing quite a lot of writing as well up of cases of some of our literature, some of our data. We're working collaboratively with lots of universities. So if any of you want to just join in with some of this, please contact us and let's work together, really. That's okay. So I don't know whether you want to say anything, Katie, just as a final farewell.
I just want to say thank you to everybody. I appreciate we're all probably on different time zones, because I see we've got somebody from Argentina, someone from Trinidad. I think that's amazing. That's what's so wonderful about you, Louise, is that you've got such a global reach. But yeah, I would echo what Louise says. If you would find future sessions, it might not always be with Louise. It's already been mentioned, she's going on tour of the next couple of months, but we've got lots of clinicians and we can put Q&As on if you'd find useful. So yeah, please do pop it in the chat if you'd find something else. It might not be on dosing, it might be on something else to do with women's health.
Yeah, and if you don't mind writing where you're from, I think it's really. I just had a message from Tash, who I know well, who's from Singapore. So it's just quite nice to know, it's a global problem, menopause, isn't it? So yeah, if you don't mind, it was just nice to know that we're helping in other countries too. So thank you very much.
Excellent.
Yeah. Thanks
London,
very much for everyone.
Great.
And just to remind you that we'll be sharing a recording of the webinar. So if you've joined late, you'll have a chance to watch it from the start, as well as Louise's slides and the all-important feedback form as well. So you can tell us more about what you'd like to hear from us in future. So thanks very much for joining everyone tonight. It's been great. Thank you, Louise.
Thank you. Thanks, Kat.
Thank you,
Thanks, Katie. Bye.
Bye.